So as he introduced, so I am a hardcore critical care medicine specialist practicing since almost 10 years in major quaternary referral center in India. Today, I'm going to discuss a major part on COVID-19 management in intensive care unit, what a respiratory therapist should be aware. So this is the need of the hour. So we are going to definitely have more and more burden in the coming days, and we have to be have a proper preparedness for managing patient in critical care unit. So here, one thing you have to understand, so it is saving the life of the patient, along with we have to save ourselves also. So it's very important each step whenever you are taking care of critically ill patient with COVID-19, self-care is very important. Self-care is the dictum for any of the person who involved in the care of the patient, particularly respiratory therapist. So I'll just go through initially a bit basics on virus and its symptomatology. So I'm going to slowly narrow down to managing the patient in intensive care unit. So I'm not going to discuss anything which is pharmacology, means like what currently therapeutic option in terms of the drugs available, what are the clinical trials, and what are currently available bit experience or evidence on particular antivirals or some anti-malarials which currently having lots of pros and cons. I'm going to narrow down to the care of patient in relation to respiratory therapist. When it comes to a bit on the virus, we know that COVID-19 is also called as novel coronavirus. So before 2019 December, before we get a epicenter viral pathology from Wuhan, China, there was no much data on this so-called COVID-19. It is an RNA virus. So we also call it as SARS-CoV-2. So it's a basically coronavirus group, that is a beta coronavirus group. So then we have to know a bit about the spread of this virus. Being an healthcare provider, particularly when it comes to respiratory therapist who revolves around the respiratory system in terms of the care to critically ill patient, you should be aware about a basic knowledge how the virus is going to spread. So when it comes to spread, we have in general 3 transmission routes. That is, one is droplet, contact, and airborne. In general, I am telling. So when it comes to contact, we have in particular in our ICU in Indian scenario, we have gram-negative organisms like Klebsiella. So when we discuss about the ventilator-associated pneumonia, so Pseudomonas, Acinetobacter, so all the gram-negative bacteria will spread by contact. So when it comes to COVID-19, which can easily spread in the same way of contact transmission. So droplet is something which is a bit bigger than that of the airborne particle, so which is around 5 to 8 micron. So it's going to like settle in a distance somewhere around 3 to 4 feet. So when it comes to COVID-19, some major way of spread is from the droplet and that of the contact. Again, when it comes to airborne, lots of confusion initially. So whether it will spread by airborne or not, till now the conclusion is it can spread by airborne also, because when the droplet get break down into smaller particle, it can spread by airborne. Most common disease in Indian scenario which spread by airborne is tuberculosis. So whatever the care we are going to take for TB might require to COVID-19 also. So when it comes to spread, it can spread from one person to other person. Droplet can settle down on the surface of a bedspread or maybe side rail of the bed or the cot, door handle, monitors, laryngoscope blade, laryngoscope handle, so oxygen saturation probe, or on the ventilator surface for 12 hours to 3 to 4 days, depending upon the environmental temperature and that of the humidity and the surface on which it is going to settle. So you have to be very careful. So it is having a huge burden of spread by droplet and contact. When it comes to infectivity, so you should be aware, because when a patient comes with some symptomatology, you should be aware what is the range of infection. So in terms of the duration, it can be somewhere from 3 to 21 days from the beginning of their some sort of like prodromal illness. So to the maximum 21 days, the infectivity will be there. So remember, more sicker the patient, more highest will be the infectivity. So more sicker means those patients who are in ICU, definitely they are sicker, more infectivity will be there. So main incubation period is around 2 weeks, but the mean incubation is around 6.4 days. So the mean time of quarantine required according to the data available, which was around 6 days, but it should be like stretch over a period of 2 weeks, that's up to 14 days. Remember, more dangerous are the patients or the person who are not going to mount any symptom. Suppose like an young, maybe around 20 to 30 year, so he might have a very mild symptom of some sort of sore throat or maybe just myalgia. Okay, so he might not bothered about his symptom, so then he is going to take some bed rest, but he is going to carry the virus and he is going to spread the virus like anything. So basically, asymptomatic patients are the more dangerous in terms of spreading the infection from one person to one person, because even though he is asymptomatic, he can spread the infection to more susceptible patients like immunocompromised, elderly, or maybe pediatric age group. So they are the more dangerous. So when it comes to symptomatology, see, being a respiratory therapist, you should be aware. So what symptoms the patient will come to, particularly hospital and ICU. Because see, I initially told we are the person, respiratory therapist is the one person who is going to deal in depth with the respiratory system. So the symptoms also revolve majorly with a cough, breathing difficulty, and fever. This is the data available till now from the Wuhan, Italy, and the Spain. But interestingly, so it can present atypically also. Lots of data currently available. So some patient, they can manifest with the gut gastroenteritis with increased frequency of the stools, that is the loose motion. Or in Italy, so recently we got the data, young patient died because of COVID-19, that is because of myocarditis. They can have cardiac arrhythmias, they can present with the chest pain, palpitation. So that may be the initial presentation. They might not have any fever or cough or breathing difficulty. So remember, so these are some atypical manifestation. When we go in-depth analysis of the symptomatology, these are the symptoms we are getting in relation to COVID-19. So what is the prognosis? So whether we need to worry about the infection per se, see, when it comes to severity, so we calculated the severity percentage from the patients, those who are reported to the healthcare unit. Suppose I told initially, the patient is young, so is asymptomatic, is not going to reach the any medical attention at all. So then we are not able to calculate that percentage. So whether the prognosis is good or bad. So overall, available data suggest more than 80% of the patient, they are not significantly ill and may not require hospitalization. But when it comes to hospitalized patient, near about 10 to 20% they require ICU admission. Among them, near about 2 to 10% they require endotracheal intubation and mechanical ventilation. Mortality so may spread from 1.5 to 2 to near about 5 to 8%. If you see the mortality from Italy and Spain, it reached up to 8 to 10%. But when it compared to mortality in German, which is about 0.75%. So when it comes to death rate, lots of confounding factors are going to be involved. It may be comorbid condition of the patient, immune status of the patient, how severely the patient presented to the intensive care unit, or their age as a major factor, which is the determining when it comes to death rate. So again, should we have to be panicked? This is the initial data which comes from China, Wuhan. So they included, which is published in NEJM, so in February end. So they included near about 1,100 patients who are COVID positive. If you see, near about 2.3% only they required endotracheal intubation and invasive mechanical ventilation. Overall mortality was 1.4%. Again, whom to get worried? Definitely younger people. So like the symptomatology is going to be mild or maybe moderate. The mortality is also very minimal in young patient. So they are not at risk. The elderly who are more than 65 to 70 years or the more are going to have the severity of the illness. Again, so this is one slide which explains near about 42,000 medical staff, healthcare providers, including the respiratory therapist, nursing staff, doctors involved in caring the patient in Wuhan of this COVID-19 initially. But if you see their mortality, it was 0%. What it tells is, if you have an adequate personal protective mechanism, so personal protective equipment with taking consideration of proper preventive aspect of infection control policies, you can avoid the mortality among healthcare provider. It's very important. So whenever you take care of the COVID-19, remember, recall, practice personal protective equipment and personal safety as the first priority. So again, to remind you, near about 80% of the patient might not have any severity of the illness. They are going to get cured. So don't be panic. So it is the transmission speed is very rapid than that of the bad outcome with the COVID-19. Even though we have some bad experience from Italy and the Spain, so but overall outcome is not so bad as compared to H1N1 pneumonia. So again, to understand what are the general risk factors, so elderly, which I already told. So male sex, available data suggest like male sex is having a more additional risk factor. Those who are already having COPD, bronchial asthma, so cardiac diseases like chronic hypertension, coronary artery disease, so those who are having previous stroke, cerebral vascular diseases, diabetic, those who are under having some steroid therapy, or if they are having some immunocompromised status like retroviral disease or post chemotherapy, post transplant patient, these are the general risk factor to have a sickest manifestation because of this COVID-19. So what general preventive measures? So it applies to all the healthcare category, that is particularly to respiratory therapist, including the staff to the students. Okay, you should be aware these utmost general preventive measures. The only way to prevent infection during the pandemic is to avoid the exposure to the virus. Okay, so wash your hands with the soap and water, alcohol based hand rubs. Okay, avoid touching eyes, nose, mouth with unwashed hands. Maintain at least a distance of 3 feet so that the droplets are going to settle within 3 to 4 feet. So practice proper cough etiquette and respiratory hygiene. So seek medical advice if you have fever, breathing difficulty or cough. These general preventive measures everyone should remember. So again, use mask appropriately. This is the impact when the countries neglected using the mask in an appropriate way. If you see the spike in US, Spain and Italy, it is exponential as compared to those countries where they used appropriate mask as a personal protective equipment. Again, a bit on diagnostic test, because see, being a respiratory therapist, you should be aware, okay, a patient came with some sort of mild symptoms. Okay, so if they initially get some diagnostic, if it is negative, what it means. Okay, so basic idea you should be aware. So majorly we can diagnose COVID-19 so on the basis of like some respiratory secretion, something from the blood, some imaging modality. So when it comes to most commonly done diagnostic modality, it is PCR technology. So when you send the PCR test initially, okay, within 3 days, there is a high possibility PCR may come as negative. So initial negative test for COVID-19 within 3 days doesn't mean they don't have the infection. So at least you need 3 days for the PCR to get positive. That one point you have to remember. So when you are giving the care, so when you have a suspicion of COVID-19, suppose PCR came negative within 3 days, it doesn't exclude the infection. That is the take-home message for all of you. Again, when to do the antibody test from the serum? So IgM, which is going to appear somewhere on the end of 1 week, and it stays in the body for about 21 days. IgG is going to appear after 2 weeks of the illness. So when it comes to imaging, so again here you have to remember, imaging means either a chest X-ray or CT scan. Take care of yourself with the appropriate infection control and preventive measures. So X-ray, in about 75%, it's going to have the bilateral infiltrates, but in about 25% of the patient, it can have unilateral infiltrates in the chest X-ray. When to consider CT scan? Okay, do you require CT scan in all the patient? Answer is no. When the patient is having a suspected pneumonia, X-ray is not showing any patch or any infiltrates, patient is bit deteriorating, the strong suspicion of the COVID-19, you can get CT scan. So CT, one important thing is, which gives some hint prior to the PCR test become positive. So it is very important. CT can guide, give some evidence before the PCR test is going to be positive. What are the findings in CT scan? Which can be multiple bilateral lobular subsegmental consolidation areas, or most commonly ground glass opacities. So this is the most common finding in CT scan when it comes to COVID-19. So again, see, in our unit also, we involve most of the respiratory therapists in taking the sampling also. So suppose it may be H1N1. So we used to take the help from the respiratory therapist to take the sampling for diagnostic modality. So being respiratory therapist, you should be aware. So you should be properly prepared with the personal protective equipment, with a face mask, eye protection, cap, double gloves, full apron, full body gown. So all these things are very important, with the leg cover and all, very important before proceeding to take the sampling. So most commonly we can take the respiratory sample either by nasopharyngeal or oropharyngeal, that is the throat swab. When it comes to nasopharyngeal, make sure your measured swab length may be somewhere from the external ear to that of the nostril. Just slowly go inside the nasopharyngeal cavity, you will get a bit resistance. Keep the swab for a minute there. After that, slowly roll it and remove without any spillage. It's very important. Don't make the spillage of any secretion. It can cause a droplet spread. So during the sample collection, again, throat swab. So avoid the tongue, or don't take the saliva. Touch the posterior pharyngeal wall or the tonsillar bed to take the sample with the utmost personal protective equipment usage. So again, the blood sample. So most of the time, nursing staff are going to draw the sample for serological test for antibody detection. But make sure if you are assisting in taking the sample, use appropriate personal protective equipment. Again, is there any role for bronchoscopy when it comes to diagnosing COVID-19? Answer is no, because there is an enormous risk of transmission to care provider. It is an manpower consuming procedure. Suppose for bronchoscopy, at least you need 3 members. Okay, you have to wear the personal protective equipment. When we have the scarcity of the supply of even face mask and the sanitizer, don't waste in using PPE equipment just to do the bronchoscope. Only bronchoscope is indicated. Suppose the patient is immunocompromised. So patient is a post-emeral lymphoid malignancy or post-transplant patient or retropositive patient. You want to check for some sort of pneumocystis pneumoniae or invasive fungal infection like invasive aspergillosis, then only bronchoscopy is indicated. But make sure you use appropriate personal protective equipment. Bottom line, so don't use bronchoscopy for diagnosing or to exclude the COVID-19. Again, which is the best test? I told initially, so currently PCR is the best test as compared to antibody testing. CT gives an idea regarding the COVID-19, even though the findings are non-specific, but at least it tells some idea about the COVID-19 before PCR is going to be positive. If you club PCR with CT scan, the sensitivity is near about 100%, but the sensitivity with the PCR alone, somewhere it's about 65 to 70%. So that too after 3 days of the onset of illness. Antibody test, which helps in after like maybe 2 to 3 weeks of the illness. Again, antibody detection helps for some sort of calculating the prevalence in patients who don't have the symptoms, but they are the carrier of the virus, or if they manifest mild symptomatology. To understand the herd immunity, also we need to check the antibody level. So when it comes to complications, I told about the symptoms. When it comes to complication pertaining to respiratory therapist, so we are worried about the complications which are in and around the respiratory system. So reported incidence of ARDS among the patient who are going to get admitted to ICU, somewhere between 20 to 30%. So acute respiratory failure overall incidence is about 8%. So other reason near about like 7 to 15%, they can have cardiac arrhythmias. So like secondary bacterial infection can happen in about 10% of the patient. Near about 4 to 8% of the patient can present with secondary infection with a septic shock, with a hypotension, hypoperfusion and all. So majorly, most manifestation as a complication, being a respiratory therapist, we worried about respiratory failure and ARDS. So that is about 17 to 30%. Again, there is a bit difference when it comes to pathophysiology of ARDS in patient with COVID-19. So it is not like pulmonary cause for ARDS. We know that ARDS causative can be divided into pulmonary and extrapulmonary. That is also divided as so primary or secondary ARDS. So when it comes to pathophysiology in relation to COVID-19, ARDS can happen because of the virus directly, which is going to affect the endothelial cells and pneumocytes of the alveolar capillary membrane, which cause leaky capillary and can cause interstitial edema, that is non-cardiogenic. So on the other hand, it can lead to lots of cytokine release, like we call it as cytokine storm, interleukin 1, 6 and TNF alpha, which mobilizes the WBC, particularly neutrophils, into the lung, which can again in turn like generate some more cytokines, which leads to the damage to the barrier membrane and leads to leaky capillaries and interstitial edema. So both direct and indirect mechanism are going to be involved in the pathophysiology of the ARDS when it comes to COVID-19. So there are some data which suggest there is something called macrophage activation syndrome. It is also called as hemophagocytic lymphohistiocytosis syndrome, which present with lymphopenia, means lymphocyte count will be low, okay, along with thrombocytopenia, some LDH, triglyceride, ferritin, C-reactive protein is going to be elevated. This is also one proposed mechanism of pathophysiology. So recently we got some manifestation in relation to heart, that is the myocarditis, cardiomyopathy, arrhythmias, and it can also have some gastrointestinal tract manifestation in terms of acute gastroenteritis. This is the overall pathophysiology of the COVID-19. So when it comes to ARDS, I told initially, slowly from the general aspect of the COVID-19, what a respiratory therapist should know, what a healthcare provider should know, I'll slowly move on to the like respiratory system, narrow down to respiratory therapist approach. So when it comes to ARDS, this is the initial paper. They try to assess the risk stratification among the patient. It's a retrospective data. They collected the data somewhere in between January and February, near about 200 patients they included. If you see elderly population, neutrophilia, organ dysfunction, those who are already having coagulation abnormalities, ARDS in its severity and increase in mortality. Again, one more thing they found is, see, those who are going to have the manifestation of high grade fever, they will have more and more chance of ARDS. But even though they had high grade fever, the overall outcome is good. It means somewhere it suggests those who are having a immunological manifestation in the body, their outcome is going to be better in terms of COVID-19. But the problem with this study, so it's a retrospective single center study, so lots of selection bias. They were not having appropriate preparedness when it comes to managing initial epidemic in the Wuhan, China, when it comes to COVID-19. Lack of preparedness was also there, but still there is a hint, okay, elderly, immunocompromised, organ dysfunction, coagulopathy, high grade fever. So all these things are linked in and around to development of ARDS. Again, what is the role of respiratory therapy, respiratory therapist during this pandemic, where they are all expected to work? It may be in the ward area when we have not confirmed the COVID-19, but we suspected the COVID-19 based on their symptomatology, that is fever, cough, and breathing difficulty. Or we already confirmed, but they don't require ICU therapy. We clubbed in an isolated area that is called cohort isolation. So they are expected to work there also, or in the emergency room, in the triage areas, recovery room when the patient got bit improved in HDU or step down ICUs. Mainly the role is in the intensive care unit when it comes to respiratory therapist. So again, move on. So suppose, okay, you are the respiratory therapist available in the duty. Suppose you got some information, okay, patient with a suspected COVID-19 with some respiratory symptoms is going to admitted to the ICU. What precaution you are supposed to take? So try to get the initial assessment from a distance of not less than 6 feet. Okay, don't jump on the patient. If the patient is a bit stable, so try to evaluate the patient as the patient from about 6 feet. So as long as, like, if you put the face mask on the symptomatic patient, if the patient is coughing, first thing you have to make is, like, make sure they should wear a simple, at least a face mask. Then you start evaluating the patient so that you can avoid the burden of droplet spread. Suppose if no suspicion of the infection, that is with the COVID-19, at least you have to follow regular universal standard precaution when you evaluate the patient. If the patient came from the emergency room or the casualty with the nasal cannula with maybe 2 to 3 liter of oxygen, on the nasal cannula, put the face masks to them. So at least it will avoid the burden of droplet spread of infection. This is very important. Again, suppose you need to transfer patient, being a respiratory therapist, you are going to involve in transporting the patient from one unit to other unit, or maybe one building to other building within the same hospital campus. First, you get the information from the emergency medical service, is there is any suspicion of the COVID-19, okay, or it's a proven case of COVID-19. So again, avoid, like, as much as possible relatives and other caregivers in the particular vehicle where you are transporting the patient. Suppose how a driver can get protection if the separate cubic is there for the driver. So make sure all the windows and the doors which separate the driver cubic from that of the patient should be closed appropriately. Sometimes you might not have an adequate separate chamber for the driver in some vehicle. Then make sure the outside air vents in the near to driver are totally open, and you switch on the exhaust ventilation in the patient area, so to the maximum speed. So then at least this will create some negative pressure, so which helps in so preventing the aerosol spread of the COVID-19. So open the air vents near to the driver and switch on the exhaust ventilation fan to the maximum speed in the patient area, which creates some negativity. So it's very important. These precaution at least you can take it during transport of the patient. So when it comes to, like, admitting the patient in intensive care unit, you need to understand some logistic issues. Where to keep the patient? Keep the patient in negative pressure isolation. Suppose with the high burden you might not get negative pressure isolation, you can cohort them in particular isolated area with all COVID-19 together. That is called the cohort isolation. So convert, maybe if you have a problem with getting the more and more ICU bed, your HDU, So step down ICU, recovery room, operation theater may need to get converted into intensive care unit beds. At least maintain 6 feet distance in between the patients. When it comes to manpower, we know that the nursing we require 1:1 allocation. So at least I expect one respiratory therapist for 4 ventilated patients. So it's very difficult to provide 1:1 respiratory therapist. At least 2 to 3 patients it can look after with very bad criticality among the patients. So the shift should not be like more than 6 to 8 hour shift, because if you wear that personal protective equipment, it is very difficult to stretch the duty hours more than 6 to 8 hours. So your shift should end somewhere in between 6 to 8 hours. Proper preparedness drill on donning and doffing is very important. Remember, so wearing a PPE is very easy, but when you remove after closely worked with the COVID-19 positive patient, that is the doffing of PPE is very important, because that is the time when you get most of the infection which are going to cause the self-harm. So you have to prepare, practice, proper drilling should be needed before you go for donning and doffing of this personal protective equipment. So other rota, so depends upon your institution. So you should get a good moral support from your senior staff or your consultant in charge, so that you are able to work with COVID-19 positive in a risky area properly. You need a support mentally, physically. Okay, so don't stretch after continuous 5 to 7 days of your duty. After your 7th day, at least you need some sort of quarantine for at least 10 to 14 days. It's very important. So don't burden our the working hours also. Don't stretch more than a week when you are closely involved with managing the COVID-19 patient. Again, suppose like you are working in a ward area or the cohort area. So this is something early warning score for NCO patient, that is the COVID-19 patient. These are proven patient. You can use some criteria like 0, 1, 2, 3. That's the risk stratification based on age, respiratory rate, oxygen saturation, whether they require supplemental oxygen or not, systolic blood pressure, heart rate, level of consciousness, and the temperature. It's very simple. Okay, if you follow this chart, so at least you are able to risk stratify when and which area you need to take the patient. Suppose you are working in the ward where you have like proven patient in a cohort area. If the score is 0, 1 to 4, 5 to 6, more than or equal to 7, more than or equal to 7, and which is moving to color code, that is black from the red. So according to that, so you can change your monitoring to 12th hourly, 6th hourly, hourly, or continuous. And according to the severity, you can consider where to keep the patient and when to approach critical care rapid response team, that is the RRT team. So this is a simple way. So you can trouble identify and troubleshoot if you are working in cohort area. Because in my unit, so respiratory therapist we have in ICU, we have in sleep lab, we have in pulmonary function test area, we have in ward area also. So those who work in ward, respiratory therapist, they should be aware of this COVID specific risk stratification charts. Again, narrow down to airway control. So coronavirus COVID-19 airway control. So it is very important. So appropriate preparedness, stock protection. So all the movements should be attached with personal protective equipment. Hand hygiene, full PPE, minimize any method which generate the aerosol. Airborne infection isolation, negative pressure isolation is mandatory. So if you are able to get, so prepare the drugs and equipment. Explain to the nursing staff also what you are expecting, what equipment need to be ready. Formulate the plan early. So assess the airway. If the patient is having any obese neck or Carmax grading is very bad, so our Mallampeti grading is very bad. So it is like you have to evaluate the difficulty, anything you are going to face in terms of intubation. So connect the bacterial or viral filter to all the ventilator circuits, particularly expiratory limb. You keep everything ready. So you have to be get ready video laryngoscope or the conventional laryngoscope with the blade and the lighting checked thoroughly. Again, during the intubation, it's very important to give weightage to team dynamics. clear delineation of the roles is very important. You tell, okay, person A, you take care of the suction, person B, you take care of the medication, person C, you go to the head end, you give the cricoid pressure, you monitor, you like manage the oxygenation of the patient. You have to be properly allocate the role, closed loop communication, clear communication of airway plan. You should be aware, okay, with your consultant, whether you are going to put a 8 number tube, 7.5 number tube, okay, what airway size you are going to use, what laryngoscope you are going to use. Airway plan has to be adequately made. So cross monitor each and everyone for the good personal protective measures. So when it comes to proper airway management, so most experienced person is going to put the endotracheal tube. So when you give the oxygen, so don't keep like 10 liter 12 liter and all, because more and more oxygen, so it can develop the aerosol production. So minimize the oxygen flow just to keep the saturation in an acceptable way. Use the tight mask, don't create any leak. So proper rapid sequence induction is very essential. Avoid bag mask ventilation as long as possible. So inflate the cuff. Only you ventilate after inflating the pilot cuff. Otherwise, patient is going to generate like aerosol, which is going to be harmful. After the intubation, avoid unnecessary circuit disconnection. Okay, suppose if at all you need to disconnect the circuit, clamp the endotracheal tube. So strict adherence to the proper doffing is very important. When you remove your PPE, make sure you follow all the steps, because that is the time when you can get self-infected. Proper hand hygiene, and again debrief what you have done, what went wrong, and what need to be prepared next time when you go for the airway control of the COVID-19 patient. So these are some additional protective mechanism. Okay, so you can use some acrylic made glass chamber to avoid the droplet spread for the self protection, or you can put a transparent polythene so that you can prevent the spread of droplets. These are some alternative methods Indians have developed, and definitely they help in their own way when it comes to spread of infection during airway protection. When it comes to ventilation properly, so in a non-sicker patient, somewhere target oxygen saturation in and around 92%. If they have a hypoxic respiratory failure, SpO2, you need to target somewhere around 96%. So in ARDS, use low tidal volume ventilation. That applies to other patients also. COVID-19 also maybe somewhere around 4 to 8 ml per kg. Which weight? That is the ideal body weight you need to calculate according to the sex of the patient, and you have to ventilate according to ideal body weight, not the actual body weight. So use the PEEP according to ArtsNet PEEP FiO2 table. Okay, need not to adhere to the same values, but you can take the guidance to alter the PEEP and FiO2. Keep the target of end inspiratory PEEP plateau less than 30, or driving pressure, if you are able to understand, that is the PEEP plateau minus PEEP, keep it less than 15. So keep patient always adequately sedated. Use the muscle relaxant if they are severely hypoxic. Maybe if the patient is having a PF ratio of less than 150, keep them paralyzed at least for initial 48 hours. So when it comes to fluid management, so keep them bit dry, because accumulated positive fluid balance is going to have a bad impact on the ARDS. It is going to create more and more pulmonary congestion. It may have problem with oxygenation of the patient. So keep them a bit negative fluid balance. So one practical aspect which tried in Indian scenario, so this is the ventilator. Okay, if you see, they have removed the ventilator where we get the graphics, okay, where we are going to manipulate PEEP, tidal volume, FiO2, respiratory rate, than that of the body of the ventilator. This with the extension of the wire, they kept outside the isolation room. So it's a good idea. The same thing we can do for the monitor also. Same thing we can do for the infusion pumps also, so that we can avoid repeatedly going in close to the patient, so that we can avoid the distance, we can maintain the distance from the patient. We can definitely avoid the spread of the infection to the healthcare providers, particularly respiratory therapists, because we are the one who are going to manipulate PEEP, FiO2 and all. If you do something, some alternative like this, you can definitely avoid close contact with the patient very often. Again, should we consider proning for all the patient? So prior to proning, optimize the conventional ventilation, adjust the PEEP, FiO2, tidal volume. So give them a proper so-called lung protective ventilation. Still, if the patient is having a PF ratio less than 150, then you can consider going for prone ventilation. Again, remember, don't jump on prone ventilation for all the patient like other cause for ARDS, because prone ventilation is very labor intensive, lots of exposure to the healthcare provider, particularly respiratory therapist. You can get self-infection during the proning procedure. But saying that, if they are still having a refractory hypoxemia, which is very profound, you can consider going for the prone. So this is the protocol which we used already. So you optimized the ventilation for 12 to 24 hours. If the PF ratio is still less than 150, then you can go for prone ventilation. If it is more than 150, you can still go for conventional ventilation. Again, this is something interesting we got from the well-known Luciano Gettinoni. If you remember this name, Gettinoni is the one who done lots of things in ARDS management. Okay, lots of maneuvers, lots of papers published from this Gettinoni, including the Prosava trial that is on prone ventilation. So he given some thought process based on some experience, currently whatever they managed the patient. So what is the conclusion on the ARDS presentation in COVID-19 is bit atypical as compared to the regular ARDS patient. Why it is atypical? There is a dissociation between so well-preserved lung mechanics and severely hypoxemia. One thing you have to remember, so these COVID-19 patients, they look normal, okay, but suddenly they deteriorate in terms of oxygen requirement. They become hypoxic suddenly. But when you see the lung mechanics, suppose if you see their compliance is very well preserved, but they are severely hypoxic. How we can explain? It can be explained only there is a loss of regulation of hypoxic vasoconstriction. So there is a altered perfusion of the lungs. What is going to happen in ARDS in COVID-19 patient is there is an increase in shunt fraction. It means so patients are going to get like blood supply more and more into the lung, which doesn't have any proper ventilation. Means hyperperfusion of gasless tissue, which leads to increased shunt fraction. This is the main problem, which is not like manifesting regular our ARDS patient as compared to this COVID-19. So what is the impact? Suppose if you give non-invasive ventilation or CPAP to an ARDS with COVID-19, so they generate more and more negative inspiratory pressure, which leads to increase in transpulmonary pressure. That is the P plateau can jump more than 30, so which leads to self-inflicted lung injury. That may be in terms of ventilator-induced lung injury, that is particularly valve trauma. Means, so spontaneous breathing with NIV, with CPAP, it is going to create a very bad, because we don't have any control over the tidal volume. Tidal volume is the one which helps in preventing the mortality, that is the low tidal volume, preventing the valve trauma. When any intervention which doesn't have any control on the tidal volume, we can't give any low tidal volume with NIV. Okay, it depends solely on the patient's inspiratory effort, which can create more and more lung injury. Second point, suppose if you give more and more high PEEP, but the lung is very good compliant. Okay, there is no question of recruitable lung in COVID-19 patient. But if you give more and more high PEEP, if you increase, it will increase the intrathoracic pressure more and more positive, decreased right-sided venous retin, decreased cardiac output, hypotension, unstable hemodynamics. At the same time, which can have some impact on the renin-angiotensin mechanism, leads to fluid retention. So don't unnecessarily keep on giving the PEEP in COVID-19 ARDS, because their lung is very well compliant. You can manage them with a minimal PEEP in terms of your achieving oxygenation goal. So next is proning. I told, so even though someone who is refractory hypoxic, you can consider proning, but COVID-19 ARDS is going to have a very good compliance. Okay, don't create proning in all the patients with a COVID-19 ARDS, because it is going to have a lots of manpower consumption in the same time. So it is going to have a problem with the droplet spread to the caregiver, and it may not be required because their compliance is very good. Bottom line, after considering that, so they recommend ventilate the patient with COVID-19. So to buy extra time with a minimum additional damage, the lowest possible PEEP and gentle ventilation may not require jumping on the prone ventilation and high PEEP for COVID-19. This you have to remember, because the presentation of ARDS in COVID-19 is bit atypical as compared to regular ARDS patient. So should we go for recruitment for all the patient? If you see both the X-rays, which patient is going to get benefit? So if the distribution is more diffuse of the infiltrates, moderate to severe ARDS means the PF ratio is somewhere less than 170, 180. So without any cardiogenic pulmonary edema, extra pulmonary cause, they will get some benefit from the recruitment. Again, so something which looks recruitable may not be recruitable at all. So don't jump on going for the recruitment maneuver for all the COVID-19 patients also. Again, what add-on therapy? The question is, should we give the steroid in ARDS patient with COVID-19? For not all the patients, okay? So if they are just ventilated with some sort of respiratory failure, doesn't have severe ARDS, don't give the corticosteroid. If they have mechanical ventilation with the respiratory failure, and if they are having severe ARDS, then you can give systemic corticosteroid. But still, currently we don't have major data. We need more and more data, but we have to wait for some convincing evidence. Till that, we just individualize the steroid therapy. Again, what to use for like fever? You can simply give paracetamol as compared to other NSAIDs for controlling the temperature. So when it comes to extubation, make sure at least 2% should be present. Full personal protective equipment is very essential. So don't encourage them too much coughing. If at all you want to check their coughing, so just check before disconnecting the circuit. Be prepared for the reintubation. This is again something which you can do during the extubation also. Cover them adequately with a transparent polythene so that we can avoid the droplet spread. Again, a bit on high flow nasal cannula. So this is some interesting study they have done in Singapore. What they have done, healthy volunteers, they have taken 5 members. They were just checking the coughing distance because of the high flow nasal cannula. So what they have done, so they put the high flow nasal cannula and without high flow nasal cannula to understand the distance of coughing and the distance of cough effort. So there was about half-meter difference between when you put the patient on high flow nasal cannula, the cough distance can be increased to half a meter. So that's why, suppose if you want to use HFNC in COVID-19 patient, make sure you use proper personal protective equipment and use the HFNC in negative pressure airborne isolation room. Again, if you increase the flow to more than 60 liter per minute, there is a chance you can convert the droplet into aerosol infection. So make sure maybe you can keep the flow somewhere around 25 to 30 or maybe 30, 35 kind of this one, and manage the patient with HFNC with proper personal protective equipment in a negative pressure isolation room, not in a regular ICU. So again, some practical points to remember. So whenever you are using NIV, avoid using NIV first of all, but if you are using, optimal fit is very essential to prevent the dispersion of exhaled air. Discourage the use of high flow nasal cannula when you don't get any airborne isolation like negative pressure isolation room and all. Intubation should be done by an expert. Backup airway plan should be always ready. Avoid bag mask ventilation. Pre-oxygenate with non-aerosol generating means. Again, if manual bagging is required, so you can use supraglottic airway devices like laryngeal mask airway and all, but we need more and more experience on that, because at least if you use LMA, it will give a good seal so that it will prevent the droplet spread. Use waveform capnography to confirm endotracheal placement than auscultating them, because if you go more proximity to the patient, there is a high chance of droplet infection to care provider, particularly respiratory therapist. rapid sequence induction is mandatory in emergency intubation. Prefer rocuronium when you give the muscle relaxant because it's having a prolonged half-life, and it also having some capacity to suppress the coughing and vomiting so that you can prevent droplet generation. Cuff should be inflated immediately to avoid the leakage. Once you inflate the cuff, then only you ventilate the patient. Before inflating the cuff, don't ventilate because again it leads to aerosol generation and spread of infection to the care provider. Some more practical pictorial representation. So this is how you can put face mask on the nasal cannula or high flow nasal cannula. So don't use venturi mask, don't use face tent or track collar because there is a high chance of conversion of droplet to aerosol spread. Again, when the patient is on tracheostomy, ensure you use a closed suction catheter modality, not the open suction. Switch to HME with oxy vent adapter for tracheostomy connectors. Don't use any sort of nebulizer or aerosol treatments which are not recommended. You can use metered dose in an MDIs are preferred as compared to regular nebulizer to prevent the aerosol development. So bronchial hygiene, don't encourage them to too much cough because in regular patient you can give a proper physio, make them cough, generate the secretion, but be careful in COVID-19. Don't go for very thorough in-depth bronchial hygiene or cough producing maneuver. So whenever you are using bag wall ventilation, use filter in the expiratory wall. It may apply when the patient is having tracheostomy or when you are using orofacial mask also. Again, when you do the suction, keep an option on the ventilator, click on the suction support so that when you disconnect the ventilator for open suction, first of all, don't use the open suction so that it will avoid giving the breath so that it will not create any aerosol production. So use the appropriate filter for both inspiratory and expiratory circuit. Whenever you are changing the circuit, so take away all the assembly including the filter. These are some practical points which are very essential at the bedside for all the respiratory therapists to remember to avoid the spread of infection. So again, last bit of slides. So should we get a prophylaxis for a respiratory therapist? Again, our ICMR recommends asymptomatic healthcare workers involved in the care of suspected or confirmed cases of COVID-19 or asymptomatic household contact of confirmed cases, they should get prophylaxis. But here, see, it is not strong recommendation everyone should jump on getting the prophylaxis with hydroxychloroquine, because when you consider chloroquine or hydroxychloroquine, you have to weigh the risk and benefit, because so hydroxychloroquine or the chloroquine, they can cause very bad arrhythmias, life-threatening arrhythmias in terms of QT prolongation in the ECG. They can cause very bad nausea and vomiting. They can cause so maculopathy or retinopathy. You have to be very careful. So it is individualized selection when it comes to prophylaxis, not generalized for all the caregivers, particularly when it comes to respiratory therapist. To conclude, so respiratory therapists play a major role in caring of the patient with a COVID-19 positive, particularly in critically ill area. In the era of this pandemic, so preventive measures are very, very, very important. So personal protective equipment, quarantine, isolation principle, hand sanitization. Only about 30% require hospitalization and 4% require ICU care. Don't think we have a huge burden for the ICU of the patient, but they are potentially risky patient. Most of the ICU management of ARDS is like that of the general management, but remember, ARDS manifestation is bit atypical in COVID-19. Don't give too much PEEP. Don't jump on going for the lung prone ventilation. Follow the lung protective ventilation with a low tidal volume, conservative fluid management. So proning, assess the risk and benefit. Steroid in severe patients, individualize the therapy. So when you consider using NIV and HFNC, be prudent, understand the limitations of HFNC and NIV. Switch over as early as possible to invasive ventilation whenever possible in any particular patient. Strict infection prevention policies are very important. prioritize the therapy with limited resources. See, we are not managing the limited number of patients. We are into the pandemic. Okay, suppose a patient A who is having multiple comorbidities, 80 years age, severely hypoxic, on maximum ventilatory support, like is requiring 80% FiO2, 12-14 of PEEP, his compliance is very bad, his PEEP plateau is more than 30-32, or his driving pressure is 16-18 and all. Okay, we can't help. Okay, we can't help. So you have to prioritize the therapy. Okay, you have to understand where to put the full stop in the limited resources during the pandemics. With this, I'll conclude my session. So thank you all for listening. If you have any questions, I'm happy to answer. So you can